Hi, I'm Dr. Michelle O'Donoghue. I'm here at ESC Congress 2022, which is now back in person here in Barcelona. It's been very hot. And I'm here joined by Dr. Marco Valgamigli, who almost needs no introduction at this point, as he's been really a leader in the field of antiplatelet therapy and really specifically thinking about duration. And one of the pieces of science that he's going to be presenting here at ESC is a meta-analysis asking the question really, how does aspirin monotherapy compare to P2Y12 inhibitor monotherapy? And this is a very hot topic.
Thank you, Michelle. It's wonderful to be here in presence and to be interviewed lively. Actually, last year we did that actually remotely. You're correct. So we put together all individual patient data in a data set comparing aspirin versus any P2Y12 inhibitor. I think now it's the most relevant question than DAPT duration, because at the end of the day, you will have a DAPT phase, which can be short or less short at the end. Then you have to decide which drug of the two components to carry over. And that was the purpose of pulling all these data set together. We have 7 studies, individually more than 25,000 patients. We decided to limit ourselves to established CAD, which is very important, because some historical studies such as Capri did show a sort of a greater benefit in a PAD patient as compared to the CAD patient. We wanted to have a specific CAD question. So out of Capri, we deselected patients who qualified in the study because of stroke or PAD. We only focus on CAD patients. And altogether, that gives us 25,000 patients where that comparison took place in a randomized manner. In the P2Y12 inhibitor, we have both clopidogrel and ticagrelor. Unfortunately, there is no study comparing prasugrel versus aspirin, but perhaps there will be in the future.
Yeah, it's such an important question because I think, as you say, I feel like people are really moving towards wanting to discontinue dual antiplatelet therapy on the earlier side. And traditionally, a lot of the studies have been looking at the idea of dropping the P2Y12 inhibitor. But now there's also a growing amount of evidence to suggest that maybe we could actually stop the aspirin and continue people on P2Y12 inhibitor monotherapy. So it's important to look at all the trials that have really compared that strategy head to head.
Absolutely, you're completely right. We did also include some studies in which there was an early DAPT phase, but that phase has been excluded from the analysis. So it's really a pure comparison of aspirin versus P2Y12 inhibitor. So basically, the key question that we had is which drug should be maintained long term. Should we go for aspirin, which has a class 1A recommendation from guidelines, or should we go for a P2Y12 inhibitor, which is always recommended second line in patients who cannot tolerate aspirin?
Because the funny thing is, I think when you ask most clinicians which one causes more bleeding, a P2Y12 inhibitor or aspirin, and certainly surgeons, whenever you're thinking about going to surgery, the feeling is that the P2Y12 inhibitor probably causes more bleeding.
You are entirely correct.
But it's not supported by the data.
To convince any surgeon to operate a patient on any P2Y12 inhibitor, you are completely correct.
Yeah, which is part of why your research is very important. So go ahead and then tell us about the results.
So the primary endpoint that we specified was a composite of severe death and mild stroke, which is a classical endpoint. And that was significantly reduced by 12%. With a significant p-value, a number needed to treat in the range of 120. So there was some benefit, not a massive benefit. So you would need to treat 120 patients to avoid one of that component of the endpoint with a P2Y12 inhibitor instead of aspirin. We had a key safety endpoint, which is any major bleeding. There was a trend favoring the P2Y12 inhibitor arm, but that did not reach statistical significance. And as a key secondary endpoint, we looked to the NACE endpoint, the combination of the two, which also statistically favored the P2Y12 inhibitor. I think the very interesting findings come also from some secondary endpoints. There was absolutely no difference with respect to death or CV death. There was a trend towards a reduction of stroke, which did not reach statistical significance. The p-value was 0.078. And that came really not from ischemic stroke, which was pretty much equal, rather from hemorrhagic stroke, which was reduced by almost 70%. And finally, we did see a more than 50% reduction for stent thrombosis and a 25% reduction for GI bleeding, perhaps as expected, in favor of the P2Y12 inhibitor.
Yeah, I think that those are tremendous results because, based on data from Capri, from host exam more recently, I had recalled that there was less gastrointestinal bleeding with clopidogrel monotherapy as compared to aspirin monotherapy. But the part about the hemorrhagic stroke, if that had been there, that must have escaped my attention because I think that that's really quite striking that you're seeing that much of a lower rate of stroke for people on clopidogrel monotherapy, and
I
largely driven probably by the clopidogrel monotherapy
Right.
study.
So you're right. So we have two different P2Y12 inhibitor, and I did not say that there was a consistent effect. So we can actually at this stage claim a class effect for either clopidogrel or ticagrelor. Interestingly, that endpoint also struck my attention as well. I was honestly not expecting that result. And then we look back into the studies which were pulled together. There was a small signal not reaching any statistical significance in all of them. In fact, there was no heterogeneity for intracranial hemorrhage. And then at the moment I saw the results, I actually went back into my memory to remember the MATCH study. That was a post-stroke study, stroke or TIA, where patients have been randomly allocated to either receive aspirin, clopidogrel, or clopidogrel monotherapy. There was a massive difference for intracranial bleeding, disfavoring the EPT. And I think now with this piece of evidence now coming together, we probably can explain that finding that is not only a combination of dual antiplatelet therapy, which makes the patient bleed more intracranially. It's perhaps even more aspirin than clopidogrel per se, which is very interesting.
Yeah, very interesting, of course. And between clopidogrel and ticagrelor, you mentioned that prasugrel has not yet been studied as a monotherapy strategy. But do you think, is it fair to say that ticagrelor monotherapy has a trend towards less bleeding than aspirin? Or do we not have enough of a evidence base yet to say that conclusively?
Well, that we cannot actually state because the only comparison between aspirin and ticagrelor comes from the second year of the global leaders, where aspirin was compared to ticagrelor 90 milligram. In that study, large study, 18,000 patients, the rate of major bleeding did not differ, yet there was a trend for minor bleeding to be slightly higher with ticagrelor 90 milligram. So I don't think we can say that ticagrelor makes the patient bleed less than aspirin. I think clopidogrel makes the patient bleed less than aspirin.
So I guess as a final thought, in your practice, what are you now doing for a patient who is perhaps a few months post-PCI? Are you dropping the aspirin? Are you dropping the P2Y12 inhibitor? And if you drop the aspirin, which P2Y12 inhibitor do you pick?
That's a great question. My answer is that I started dropping aspirin since many years, so the results are in a way confirmatory of my practice already. The choice of P2Y12 inhibitor depends on the patient presentation. So if a patient has an ACS, I always use ticagrelor, and then I try to de-escalate to 60 as soon as I can, for sure in the second year. If the patient is a stable patient, I normally don't go for ticagrelor, I go for clopidogrel. I need to honestly admit that if I am dropping aspirin early on in that segment of patient, I test responsiveness to the drug.
Oh, very interesting.
Yeah.
Well, thank you again for sharing these exciting results, and look forward to seeing more research from you soon.
Thank you.
Signing off from Medscape, this is Dr. Michelle O'Donoghue.